A very good morning to all of you. Welcome to the CPD webinar series organized by Society for Health Research and Innovation. First, let me introduce you with the housekeeping rules. The webinar link will be available from 9 a.m. to 9:50 a.m. to you to join in. No late attendees will be entertained thereafter. Each attendee should have been attended till the end of the webinar to obtain the certificate for CPD points, and the CPD points are strictly adhered to the NCCPD guidelines. These guidelines are to improve and maintain the standards of the CPD programs conducted by SHRI, and thank you in advance for your strict adherence and kind compliance. You can ask questions at the end of the webinar. So if you have questions, please type it in the chat box. And if you have very specific questions, you can email us on officeshri13@gmail.com. So today our topic is caring for older people approaching the end of life. The guest speaker for today is Dr. Sithira Senevirathne. Dr. Sithira Senevirathne obtained his MBBS from Faculty of Medicine, University of Colombo in 2014, and then MD in Geriatric Medicine in 2020, MRCP UK 2022, and MRCP Geriatric Medicine 2024. He was a former senior clinical fellow in geriatric medicine and perioperative medicine in Oxford University Hospitals. At the moment, he is acting as the consultant geriatrician at the National Hospital of Sri Lanka. Over to you, Dr. Sithira.
Thank you very much for that kind introduction. So let me share the screen. Right, okay. So today we are going to discuss about end-of-life care in old adults. And this is something we often do not discuss, so I thought might be important to discuss with you today. So death sometimes is not as far as we think, and we as clinicians sometimes often do not recognize death early, and this causes some inconvenience from the patient's parties. And when you talk about end-of-life care, by definition, end-of-life care is the type of care we provide for the patients who are approaching the last year of their life. And this includes patients who are imminently dying. We also call it terminal care. That means patients who are going to die within hours and days. So how do you recognize a person who is approaching end of life? So we are not able to appropriately, accurately predict if someone is in their last 12 months of life. So we have this surprise question, which we should ask from ourselves. The surprise question is, would you be surprised if a patient died in the next 12 months, right? When you encounter a person who is having specially advanced incurable disease, you have to ask from yourself whether you will be surprised to see this patient dying within next 12 months period. So if there's a good possibility that patient might approach, might not survive 1 year, then you have to consider this as end of life situation. Looking at the end of life situations, there are several scenarios. So it could be advanced progressive incurable condition like a cancer, right? And most patients, older patients, they are deteriorating gradually over time because of general frailty. And especially if you're suffering like cognitive impairment, like diseases like dementia, which are progressive diseases. So because of general frailty and diseases of old age, they can deteriorate gradually. So it could be end of life situation. And there are situations where patients have organ failures, like end-stage renal failure. So there's a high chance from exacerbation of this organ failures, patient might reach and end-of-life situation. So we consider that also has a situation where we have to consider end-of-life care. And the other thing is, there could be a life-threatening emergency, acute emergency. For example, like a patient is having intracranial bleeding sudden catastrophic event, which can lead to end-of-life situations. Right? So When talking about end of life care, we talk about disease trajectories. Right? So if you closely look at these diagrams, the first graph is a graph which is in a patient who is having a sudden catastrophic event. So from the this axis, it's the patient's functional level, and this horizontal axis is time. All right. So someone who had been functionally very much doing well get a sudden catastrophic event like a intracranial bleeding and dying suddenly. This is one way of reaching end of life, one trajectory. If you look at this trajectory, this is a trajectory of a person probably having a malignancy, all right, rapidly progressive disease, all right. So, someone who had a higher functional level after the diagnosis, very quickly they deteriorate and they approach end of life, right? And this, if you look at this trajectory, it's a trajectory of a person who is having organ dysfunction. For example, we talked about end-stage renal failure. So what happens in end-stage renal failure? So in the background, renal function deteriorates and patient's functional level also deteriorates. And with each exacerbation, with each possibly acute renal failure, each episodes of uremia, pulmonary edema, so patient deteriorate from their baseline and then they slightly recover, but they again deteriorate with each exacerbation and ultimately reach end of life or dying phase. And this whole trajectory is about frailty and syndromes like dementia, where someone would slowly, progressively, their function will decline over time. All right. So get a better idea about this. So I will show you another graph, right? This one, the same. So this first trajectory is of a person with cancer. Second trajectory is of a person who is having, uh, organ dysfunction. Third trajectory is of a person who is having general frailty and diseases like dementia, right? And so if you look at this graph, you can see now you have if the palliative care, right? Palliative care doesn't necessarily mean end of life care. So palliative care could be started even with active treatment, right? With active treatment, at some point, if we are thinking that this person is reaching the end of life, then we have to consider end of life care, right? And and when patient is acutely dying, we have to consider terminal care, right? And it doesn't stop there. So we have to care for the patients as well, care for the patient's families, right? After the death, we call it bereavement support. Okay. And this term terminal care, the meaning of terminal care is care and support given for people as well as the families who are actively dying, all right, actively dying. And sometimes terminal care and end of life care, the terminology is sometimes used interchangeably, but end of life care, as I previously told, includes care we are giving for people who are in the last year of life, okay, last 12 months of life. When it comes to terminal care, that means the person is rapidly deteriorating and possibly in last hours and days of their life. Okay, right. So, what are the key areas of end of life care? Now, when you talk about symptom management in palliative care, we focus on not only the physical side of the symptoms, physical, psychological, spiritual, as well as social needs of a person. All right. And it's not only the patient, but we also have to focus on the problems of the families. And the care doesn't stop when the patient dies. We have to also focus on bereavement care, which we will discuss towards the end of the presentation. And but this type of treatment doesn't prolong or shorten the life expectancy. What we are trying to achieve is we are trying to make this journey comfortable for the patient and the family. Right? So this is kind of a difficult period for the patients and the families, and quite distressing period. So we are aiming to make this journey comfortable for them. So this is what we are going to do. We are going to living the journey and making the journey comfortable. All right. So let's change the directions a little bit now. And so I used this term terminal phase or the dying phase before. So as I previously told, end of life care includes care we are giving during the last 12 months of life. So when it comes to the terminal phase or the dying phase, so we have to also focus on few important things, right? The first thing is recognizing the dying patient, right? So I hope in your practice you encounter death. As medical practitioners, we encounter death, and think about this second question: how early do you recognize a dying person? Right. So if you go through the data, so this is what AI overview says. So doctors' predictions of survival of dying patients are usually higher than the actual prognosis. So this is called prognostic error, right? So our predictions are, more than at the patient's actual life expectancy. That's the usual thing. So we don't recognize death early, right? In one study, doctors overestimated survival by a factor of 5 times more than the actual prognosis. The doctors' prognostication is not always accurate. Only about 20% time it's accurate, but most of the time we are expecting the patients to live, but patients don't live that longer. So that's why I told this death is not as far as we think for some patients. So we'll discuss some real life situations and discuss whether what are the learning points of these situations. Here's scenario one. So this is about 80-year-old patient who was admitted to hospital with a SDH, right, subdural hemorrhage. And so before he had this SDH, he was bedbound and he was completely dependent for his basic activities of daily living for last 6 months following a major stroke, right? And now after admission, SDH was evacuated and he had to spend in the ICU 5 days and then transferred to ward. Now, after stepping down to ward, he developed a new ischemic stroke because now antiplatelets has been stopped because of the bleeding. And now when we start antiplatelets, what happened? SDH reaccumulated, right? So during this time of recovery, he got a hospital-acquired pneumonia and was given IV antibiotics. And within 2 weeks, he got the second episode of aspiration pneumonia. And now he is in type 2 respiratory failure, right? Looking at him, he's emaciated and having low GCS. So what do you think about this patient's prognosis and what are the suitable next steps? Can you give some answers in chat box, please? So history again. All right, I think we have some answers. Days. All right. Okay. Days. As most of the people think it's going to be, yeah, it could be hours to days. Right. Okay. There are some answers about some people think it could be months. Yeah, but mostly it hours to days. All right. Okay. So if you look at this patient's trajectory, so over last 6 months, patient was bedbound and now having a SDH. All right. Now even when you try to evacuate the SDH, patient got a stroke because antibiotics are held. Now when you restart antibiotics, patient had reaccumulation. Now he's having uh, two infections in close times as well as now in type 2 respiratory. So this kind of deteriorating trajectory, quite fast deteriorating trajectory, and I agree that the prognosis will be quite short, probably days, and probably days to like patient is type 2 respiratory failure, so it could be even hours. All right. So what are we going to do in this type of situations? Are we going to now patient is in type 2 respiratory failure? So are we going to intubate this patient? Are we going to ventilate this patient? So those are the critical questions we have to ask from ourselves, right? So I'll discuss about what happened to this patient after discussing case scenario 2. Okay. Now think about this second scenario. 82-year-old male with advanced COPD admitted with severe shortness of breath, and this is third admission this month. And this patient is severely breathless and unable to speak in words. All right. So despite the standard treatment, patient become more breathless and kind of carbon dioxide is rising. So the ward team tried to put a CPAP, and patient is not tolerating the CPAP much, and ICU was not considered. Now carbon dioxide is progressively rising. So what do you think about this patient's prognosis? Similarly, hours, days, weeks, months, hours. All right. Yeah. Few minutes, hours. All right. Okay. Right. Hours. Yeah. So mostly we think patient is having hours. So we have, I think, agreement that these patients having poor, prognosis and very short life expectancy. So think about these kind of scenarios. If you have encountered, have you done something differently in this kind of situations? So I'm going to continue CPAP, I'm going to continue mobilization, so I'm going to try something else if we agree this patient is having short prognosis. So we will discuss about this patient as well again. Okay. Now the last scenario, third scenario, 90-year-old female having advanced dementia, right? So do you know when patients having late stages of dementia, they get swallowing impairment, right? And because of the swallowing impairment, patient had 3 episodes of aspiration pneumonia over last 4 months, right? Now this time also patient had admitted with a pneumonia, and the speech and language therapy team reviewed and recommended not to give oral feeds, right? Because of risk of aspiration. The family require about oral feeding, NG feeding, and peg feeding. So what do you think about the prognosis of this patient? Hours, days, weeks, months. So advanced dementia, again, swallowing impairment, recurrent aspiration pneumonia. Months, could be weeks, months, so weeks to months. That's what we think. All right, right. So mostly these situations we don't recognize as end of life situations. That's the key problem. So if you look at what happened to these are real life situations. In case scenario one, so because patient was in type 2 respiratory failure, a tracheostomy was considered and intubation was not considered. The patient was having poor GCS, so PEG was considered. And ICU care given for 1 week, and patient was de-escalated to the ward, and patient died after 3 weeks. So possibly, patient was approaching end of life, but and we have not considered end of life care in this situation. Case scenario 2 is a COPD patient who was breathless, and patient continues to be breathless, agitated, and he is in pain, right? And what happened, we didn't de-escalate the treatment and continue the curative treatment. And at night, patient got cardiac arrest, and then CPR was continued, but CPR was not successful. And the family were uh, unhappy to see, I mean, obviously very sad to see in the morning that patient has passed away. Case scenario 3, now this patient admitted with the third episode of aspiration pneumonia, treated with IV antibiotics, and so NG, PEG, and careful hand feeding were discussed, and ultimately decided on PEG feeding. And PEG was inserted, and patient died after 2 weeks at home. So those are the 3 scenarios. And so in advanced dementia, when a patient is having problem with swallowing, so this is a feature that patient is approaching end of life. Usually, the feeding problems occur at the last stages of dementia. All right. So PEG is contraindicated in advanced dementia, and the recommendation is careful hand feeding. All right. Okay. So, so looking at these outcomes, do you think we have provided good end of life care here? Do you think we can do something differently, something better for these dying patients? Put your comments in the chat box and we'll have a discussion. Yeah, something better. We all agree we have to do something better, right? So, so this is another scenario. Yeah, so these are the questions. Can we recognize dying phase beforehand? Does dying mean a medical failure? Obviously not. So dying is part of life. It's not a medical failure. So we can't survive all the patients. There are some patients with incurable life-threatening illnesses. So it's not a medical failure. And the symptoms of the above patients, were they well managed? I think they were not well managed. And can we offer more than curative treatment? I think we all agree we can offer something better. Right. Now, this is a good case scenario. Right. In case scenario 4, 86-year-old patient with lung cancer admitted with breathlessness and chest pain. Right. So this patient has lung cancer. And this patient get breathless with slightest exertion, and with when patient is having a conversation, patient is getting breathless, all right? And patient feels exhausted, sleepy, and muddled at times, right? And this lung cancer is widely metastasized. And now, these symptoms like feeling exhausted, sleepy, and muddled at times are features of dying, all right? So sometimes we don't recognize these symptoms are features of dying. And because this was recognized quite early, this was discussed with the patient and discussed about the possible trajectory with the patient and the family. And so patient makes certain decisions about how he has to be, taken care of during this dying phase, and agrees to certain things like DNA CPR and prioritize. So what happens next? So patient symptoms, which are spiritual needs, were assessed in detail and family concerns addressed, and medications were started to manage symptoms, and spiritual needs were addressed. And then on day 2, patient became drowsy, and at this point patient is not able to communicate. So that's why I told that recognizing dying early is quite important. Sometimes if you are diagnosed dying too late, you might not be able to discuss these things with the patient and see what they really want in their last few days, hours of their life. And day 3, patient passes away, and the family concerns are being addressed, as well as offered the bereavement care. So what do you think about this scenario? So in this scenario, we have recognized death early and assessed patient's symptoms and taken necessary steps to comfort the patient, and family also involved, and all agree uh, that patient is in end of life state, and necessary steps are taken care of. Right? Right. Okay. Right. So these are the trajectories I previously showed to you. So if you carefully look at patient's history and try to identify the trajectory, it's sometimes easy to recognize whether this patient is approaching the end of life, which is very important for decision making. Okay? Right. So what are the symptoms of dying? How do you recognize a dying patient? A patient who is reaching the terminal phase. So symptoms like profound weakness, exhaustion, reduced mobility, being bedbound, and having low appetite, only taking sips of fluids can be features of dying. All right. So if you look at the patient's trajectory carefully and exclude the reversible causes, so even months before patient's death, so you could see people become very weak, they become exhausted, and they have reduced mobility, and the appetite goes down. And when it goes little bit beyond this phase, so they find it difficult to swallow medications. They become bit withdrawn and start to develop bladder dysfunctions. And some people have these visual experiences, hallucinations towards the end of the life. So some people say, I see angels coming from the heaven. So this could be visual hallucinations, so visual experiences, which could be symptoms of dying. Now they have recognized as symptoms of uh, approaching the dying phase. And towards the latter stages, people become more sleepy, drowsy, and also having reduced cognition. And often, what happens in most of our practices, we recognize death when blood pressure is going down, when someone is, I will come to DNA CPR. This question in the chat box. When someone is desaturating, uh, we recognize dying phase, but that's too late when you can't have any discussion with the patient and the family and address the issues properly. Right. So let's be familiarized with some more terms. Terminal lucidity. Right? So these patients, as I told you, when someone is approaching the dying phase, especially if they are having life-threatening, incurable illness. So over a period of months to weeks, they become less active, exhausted, more sleepy, and develop cognitive problems. And terminal lucidity, what's the meaning of terminal lucidity? So this kind of a temporary surge of energy or mental clarity of these patients who are approaching end of life. So we have seen in hospices actually when patients, having a trajectory of deteriorating trajectory, we predict that patient is entering the dying phase, and suddenly we became very lucid, and there's a temporal surge of energy and mental clarity. So this is called terminal lucidity. So very important to identify this, because that doesn't mean patient is improving. That indicates patient is probably entering the last days of life. Okay, so some people become more alert and asking for specific food, and sometimes they start to walk around and become conversative as well. All right. What do you mean by terminal agitation? Terminal agitation is a term we use for patients who become very restless towards the end of the life. Right? We also call this terminal delirium, and there are some reversible causes and of this as well. And we have to recognize those things and make patients comfortable at the end of the life. And terminal secretions or death rattle. So it's another sign of dying. And I'm sure you have seen patients who, when they approach the dying phase, what happens is their swallowing is really impaired, and these secretions, they accumulate and they sit on the throat area. So when patient breathes, that creates a gurgling sound with each breathing, right? This is called a death rattle. So very important to recognize this. So when someone is having death rattle, that indicates usually we are in the last 24 hours of life, and this could be quite distressing for the patient, distressing for the family, but not distressing for the patient, right? So it's important to recognize this, and uh, we have to tell the family and reassure them that this is not uncomfortable for the patient, but we can use few things like uh, uh, some medication to reduce the secretions, which will calm down the situation for the families. But it's not difficult for the patient anyway, right? So abnormal breathing or gasping breathing, and we also call agonal gasp. So these are abnormal breathing patterns which we can see towards the end of the life. So that indicates patient is probably having few hours to live, right? So there are early signs of dying, right, as well as there are late signs of dying. So very important to get familiarized with signs, because death recognition, if you recognize death early, can lead to a lot of not doing a lot of unnecessary interventions, but doing a lot of appropriate interventions to make the patient and family comfortable. All right. What is good death? All right. So I will give you 1 minute to share your thoughts about what do you think about good death. All right. There are a lot of answers: minimal suffering, minimal discomfort, death with peaceful mind, free from pain. Very good. Pain-free, mentally peaceful death. All right. Less suffering. Excellent. All right. I think we all agree that if we have reached the dying phase, we have to focus on comfort. All right. So if you look at the definitions of good death, so, right, free from avoidable distress and suffering for the patient, family, and caregivers. Right. We all agree on that. And in general, accord with patients and families' wishes, and reasonable consistent with clinical, cultural, and ethical standards. And this is the definition of good death. So what patients and families expect can change uh, according to the cultural context. All right. So we have to discuss these things in detail with patient and the family and try to find what their expectations are. All right. And then provide what is comfortable for them. All right. And what's the best place of death? Hospital or home? What do you think? Home. Right. Okay. Home. So, right. So what do you think is happening in our setting? Do people die at home or die in hospital? I think most of the time patients die in hospital, aren't they? So yeah, mostly hospital. I think usually what happens is in our setting, when someone is approaching end of life, we don't recognize it quite early, and we don't withdraw treatment, and patients, receive active treatment until the end of life. And most of these patients will be in the acute cubicle in a hospital, and probably with NG tube and catheter, cannula, IV drips, and probably intubated, and family is not around. Family is unaware the patient is dying. Patient is unaware patient is dying, and with a lot of symptoms like shortness of breath, pain, and when they die, we give CPR, and that creates a lot of other distress like rib fractures, suffocation. So it's really not a good death. I think mostly at the moment, most of the patients are getting. But as so you all agree, I think some people like to die at home. Some people like to die in a hospice. Hospice kind of a setting where dying patients are accommodated, and some people like when they are distressed at home, they want to be in a hospital when they are dying. So depending on patient's wishes, but mostly I agree, most of the people like to die at home and free from distress, and family probably around the patient. So that's considered as a good death, right? So when it comes to end of life care, we have to think about advanced care planning. So advanced care planning is to plan for this end of life period, right, beforehand. So we should not wait until the end. All right. So when patient is having the capacity to make decisions, better to uh, have this discussion with the patient and see what they really want during this last periods of life, right? Whether they actively want to come for dialysis, or whether they want to do something else, whether there are some patients have unfinished things to complete, and they sometimes want to see their family members. So likewise, we have to open up this discussion early and see and clearly document what the people want, right? And so we have to see what their preferences are, as well as we have to make some important medical decisions regarding patient's seeding of care, right? So these decisions could be related to patients with antibiotics. What kind of antibiotics do you want? Do you want IV antibiotics, or you just want some oral antibiotics? And whether they want ICU care, whether if it is not appropriate, we can clearly document for ward-based care, not for ICU care. And where do you want to die? So some patients might tell, I want to die at home at any cost. So if patient is delirious at the end of the life, if you have clearly documented this, can tell this is what the patient want. We have to make them comfortable at home. Don't bring to the hospital, okay? And DNA CPR is quite important, right? Do not attempt it. Cardiopulmonary resuscitation is quite important decision. All right, so we have this document now. I'll share the document. So this is one of the forms used in another country. This is called a respect form. So this is a form where we can document all these advanced care decisions. Then when it comes to DNA CPR, so we have this professional guideline now. So this practice guidelines for end of life care published by SLMA, Sri Lanka Medical Association. And if you go through page 16, 17, and 18, there's an important chapter about DNA CPR. So we have a professional guidance to provide DNA CPR now. Okay. So, the success rate of CPR is quite low, and especially in regard to patients who are approaching end of life, this is this is going to be a very uncomfortable thing to do. All right. So, what are the problems of giving CPR? It can cause rib fractures, it can cause symptoms like pain, suffocation, and it causes a lot of unnecessary anxiety between healthcare staff. So, this is if you do a CPR for a patient who is at end of life, this is not for the best interest of the person. All right. So, That's why we need to recognize dying people early and clearly explain the benefits and this low success rate of giving a CPR to a person, discuss this with patient as well as the family, and clearly document it, and possibly the team leader, consultant of the team, uh, taking the decision and make a clear documentation will be really important. All right. Right. So how to take care of a dying patient? What are the things we have to do? What are the things we should not do? Right. So and so if patient is having clear advanced care planning, we have to be aware about the advanced care planning and make sure we are doing this according to patient's wishes. And inappropriate medical interventions we have to stop, and no frequent monitoring if someone is acutely dying, no blood pressure monitoring, no saturation monitoring, no urine output monitoring, just monitor the symptoms, right? Monitor pain, monitor shortness of breath, monitor secretions, monitor for agitations. Those are the things we should monitor, all right? And mouth care is really important. Most of these patients, they breathe through mouth and they develop sore mouth as a result of it. So mouth care and keeping mouth wet is very important. And bowel care is very important if patient is tolerating it. And, and not only the patient, so caring of the family is quite important. And do not forget to complete a DNA CPR form. Right. So if you look at the symptoms of patients, distressing symptoms of patients who are dying, these are the common symptoms. So this could be physical, psychological, social, and spiritual. Okay. And pain, shortness of breath, weakness or lack of energy, nausea, vomiting, poor appetite, constipation, sore and dry mouth, drowsiness, anxiety, and family concerns. These are the common symptoms patients and families face during these difficult times. And review all medications and please deprescriptions for these patients who are approaching end of life. So depending on the comorbidities you are having, they have diabetes, renal impairment, heart failure, Parkinson's disease. So there are certain adjustments we have to do to according to the physician's advice. Right. So if you look at the management of common symptoms, so most of the patients who are dying, they lack the oral route, all right? Find it difficult to swallow tablets, as well as getting an intravenous access is would also be difficult. So there are some patients who are getting chemotherapy or having some other diseases. Cannulation could be extremely difficult, especially in older people. Cannulation can be extremely difficult. So we use the subcutaneous route instead of intravenous route. Okay, so this is a picture of a instrument called syringe driver. Okay, it's kind of similar to infusion pump where you can continue this type of medications, palliative medications under the skin. All right, this is a syringe driver. In our setting, we can use infusion pumps and put a subcutaneous cannula and administer medications subcutaneously. So if you look at the subcutaneous route versus other routes, so for the obvious reasons I have told you earlier, so the subcutaneous route is preferable. And not only the medication, you can also give fluids subcutaneously, which is the best way of hydrating these patients. Right. So we commonly use drugs like morphine, metoclopramide, haloperidol, midazolam, and hyoscine bromide. There are some other medications as well to alleviate the patient's symptoms. So these are the indications. For pain and dyspnea, we use morphine. For nausea, we use metoclopramide, or there are some other agents which we can use subcutaneously. And then agitation, we use haloperidol. And again, restlessness, we use midazolam. So respiratory secretions, we use hyoscine. Sometimes we can give these as injections subcutaneously, or either we can give as infusion subcutaneous. Right. So if you talk about respiratory secretions, so I previously told you about this thing called terminal secretion, so death rattle. All right. So I'm sure you have seen this gargling sound people get when they die. So usually families are really distressed about this symptom, and but this has been shown not to be distressing for the patient. So if you look at the nonverbal cues of pain, and discussing these patients. Most of these patients are not aware about these symptoms and they are quite comfortable. And you have to reassure the family. And sometimes, we can use a little bit of high comforting for the family, and positioning might also be important. When you look at the bladder and bowel care, so regular bowel care is important. If patient is not opening bowel every third day, use an enema. And most of these patients go into urinary retention, especially when we start midazolam hyoscine for the management of symptoms. They go into urinary retention, and most of them might need a urinary catheter. And when you talk about the nutrition and hydration of a dying person, and it has been shown when they are approaching the dying phase, the energy requirements goes down, and patients' feeling of hunger rapidly goes down. So they might not, eat much, and this is not really distressing for the person. And it has been also shown that when you are in a fasting state, you create these ketones, which also give kind of a good sensation for the dying person. So, and if you feed them by force, that can cause unnecessary distress for the patient. So, we are not trying to overfeed the patient, and no NG tubes for the dying people. And only if, like in extreme cases, if someone is having severe nausea and vomiting because of the bowel obstruction, and if you can't, use the medications like metoclopramide, hyoscine, the all other medications to overcome nausea. Sometimes, very rarely, we use an NG tube, but no NG tube for feeding, absolutely not, and no interventions like peg feeding. All right, just a little bit of sips of fluids as patient is tolerating. And when it comes to hydration, about the amount of fluid which a dying patient requires is again is arguable. There are some ongoing trials like LC2 trial where so they measure hydration of 2 to 2.5 liters versus hydration of 1 liter to see whether there any change in patients' symptoms. But current recommendation is to give fluids as much as about maybe 1 liter per whole day using a subcutaneous cannula subcutaneously if someone is not able to take oral fluids. So again, overhydration can result in a lot of unnecessary problems. For example, can increase the secretions, can increase urine output, and other problems can worsen urinary retention. And if someone is having heart failure, can worsen heart failure. So there are a lot of other problems which can happen with overhydration. All right. So these are the sites which we can use for subcutaneous fluid administration, anteriorly and posteriorly. All the people use interscapular areas as well. Right. And in regard to the place of death, we have discussed, and I think most of us agree. I mean, most of our patients prefer to die at home, but they die at hospital. So this is a picture of a hospice which I have worked as well. So, so there are, this place should be comfortable for the person who is dying, and it should be depending on patient's wish and severity of symptoms as well. Sometimes, if someone is having difficult to manage symptoms, they might not be able to meet these requirements at home. For example, who is having severe shortness of breath and might not be stable enough to transfer from hospital to home. Better to have a kind of a personal, either a side room or a cubicle which is covered with some family members around as much as convenient for the patient. So depending on patient symptoms as well. Right. So spiritual well-being is something sometimes we forget to address, but it's very important. It's not always, like putting spirit or asking uh, a religious person to come and visit the person. So you have to have good discussion with the patients and see what their spiritual requirements are. So their spiritual requirements might change widely, right? So if you talk to patients, you might understand this. For example, now, so certain religions, so they, the patients think about their afterbirth, all right? And so they are distressed about their afterbirth. Sometimes they want to speak about things to their families and or a religious person. Or there are some people who don't believe in afterbirth. So then their expectations are quite different. So you also you need to spend some time with these patients and discuss what their requirements, what the expectations are spiritually during this sensitive period. Right. Now, care doesn't stop after patient dies, and we need to continue bereavement care for patients' families who had been supporting the patient for a long time, possibly during this period, and that also we need to uh, keep in mind. Right. Communication during this period is very, very important, right? And remember that nonverbal communication plays a major role than the verbal communication. uh, it's not what you said, it's how you said it. Remember that, all right? It's not what you said, it's how you said that thing to the person. It's really important. So we have seen actually, this could be a very distressing situation for the families, and they are under a lot of distress, right? We have to always have a empathetic approach, right? You have to go into their shoes and see how distressing the situation is. It's not only sometimes giving the information, active listening is very important, and this will be a communication they will remember for the rest of their life, right? So you're going to tell someone that their mother or father is dying, all right? Or you might be telling directly to the person that they are approaching the last days of life. It's a really important, really sensitive thing to tell. So you have to be very thorough and empathetic when you are communicating this. So you will be remembered as the doctor who was given the news, all right, for their rest of the life. So that's very important. Right. So this is a picture I captured from the internet. This is a paramedical person taking a patient who was in the hospital to uh, to the beach for the last time. Okay, so it's sometimes not only the medications, all right. So these kind of things really matters for patients' experience of the dying phase, right? And we can cure sometimes, we can treat often, but we can always comfort, right? So end of life care is all about keeping the patient and the family comfortable, right? So I think we have come to the end of the presentation. I'm happy to answer if you have any questions. I'm sure you might have a lot of questions, so I'm happy to discuss.
Thank you, Dr. Sithira, for that informative presentation.
Right. I think we
So,
have some questions. Uh, can we write? So most of these questions are on DNA CPR. Can we write DNA CPR on BHT? Is there a legal issues? If we have not discussed about DNA CPR previously and family members, patient, can we do attempt CPR? Yeah. So the important thing is now, uh, I think you can understand CPR is going to be harmful for the dying person. All right. We all now discussed if we think about the good death, we don't want pain, we don't want distress, we don't want unnecessary interventions. You want to die in peace, possibly at home. So, this CPR is a very distressing intervention for from the patient's point of view. So that's why it's very important to discuss this beforehand and tell them, uh, the CPR is going to be very distressful and the success rate is very, very low. And if you are really dying, it doesn't change anything. So, and clearly document it. So you have to document it in PhD, and better to get, team leader, consultants, signature on the DNA CPR. So there are no legislations. There are no legislations in many countries, but when it comes to putting the DNA CPR order, what we have to think is the problem is whether we are doing a negligence. All right. So negligence means if you are not doing a medical intervention according to the guidelines, so you will be, sometimes told that you have done some negligence. But we have professional recommendations. All right. And if patient is clearly dying, so you can quote the professional guideline and do a DNA CPR for the best interest of the patient. Right? So it's just we are not doing a futile intervention for the patient, which can be harmful. Okay, hope I have answered the question. So what drugs can be given through subcutaneous cannula? So we have discussed. We can give fluids. We can give morphine, hyoscine, midazolam, and then a lot of other medications like even olanzapine, haloperidol, a lot of medications we can give through subcutaneous cannula.
We have some other questions which participants has sent us in the pre-survey and registering.
Yeah, yeah.
One is how to manage delirium in the end of life.
Yeah, so delirium is very, very common in end of life. Maybe about 50% more than that get delirium. And some people get agitated delirium. We call it terminal agitation. And most of the delirium is due to distressing, symptoms like pain, shortness of breath, sometimes other reversible things which we have like medications which we have to recognize and then do appropriate interventions first. And sometimes delirium is unavoidable, so we need to, sometimes the patient is distressed about this and they actively dying, we have to give certain medications to reduce the distress like midazolam. So that's how you approach delirium when patient is dying.
At which point can we refer them for palliation?
So as I told you, palliation is not only end of life care. So if someone is having incurable disease, even with active treatment, we can refer to palliative services. So we can start the discussions quite early. So then the family and the patient will be also, quite aware and comfortable when we take this decision towards the end. So referring to palliation should be quite early, even before we diagnose end of life. And when it comes to end of life, so again, we have to take appropriate decisions and discuss these things quite early, the better. Yeah. So we don't have subcut cannulas, but we usually use subcutaneous butterfly cannulas mostly in the wards.
Can we give sedation to alleviate death pain?
Yeah, definitely.
How to
So our
manage
goal is to keep the
ins-
patients symptom free. Yeah, please.
Sorry, you can continue.
Yeah, that's Samira. Yeah.
Next question is how to manage insomnia in elderly patients.
So it's not really unrelated to end of life. So it's a uh, completely different kind of topic. So I'm happy to answer any questions. I can share my email. So if you have questions, just put to my email as well.
What are
Anything
the
else? Yeah.
available social service involvement in Sri Lanka on elderly care?
Actually, from the elderly secretariat, there are a lot of social, uh, I might not say a lot, but there are some social services which are available. Most of these patients can, you know, uh, reach these services through the AG office. There's a social service officer, and they are able to provide the information to the patient if you need to get more information.
So most of the other questions you have already described
All right.
during this.
Okay. Thank you very much.
So thank you very much,
Right. Okay.
Dr. Sithira Senevirathne, for your informative lecture and your precious time. So dear participants, please find the link in the chat box, fill it, and then provide us with the feedback, and then you can receive your e-certificate for participation. So we can wind up today's session. Thank you, everyone.
Great.